Good afternoon, everybody. It's great to be back in Birmingham. I do realise that I'm standing between you and lunch, so I promise you this won't go on for longer than half an hour. I thought I'd just start with some humorous slides. This is a prediction from Cats about the past, present and future of British general practice. So, if we may. Moving to the present. Moving to the future present. And then finally, the far future. Seriously, what I'd like to talk about is, just in case you missed the major thrust of my argument, is that in the 53 countries that I've travelled to on 155 occasions, not that I'm counting, there are so many countries that would give their high teeth to have a primary care system the like of which we have in England and the United Kingdom. And so my title today is Adapting Primary Care. Not smashing it up, not revolutionising it, but adapting it, because basically the model that has existed, I believe, has inner strength and inner confidence to adapt and change for the future. Now, clearly, I also understand the pressures on GPs working in England at the moment, and I just want to show you some slides that demonstrate that I recognise that, and then show you some examples from around the world, which I believe probably already exist in parts of the English NHS, but certainly should be adopted at greater speed. So, the killer point on this slide, of course, that you know better than I, is that an increase of one primary care doctor per 10,000 population is associated with a 6% decrease in mortality. You know better than I the challenges that you face in terms of ageing and long-term conditions. The real issue, I think, if you look at the QOF prevalence and then actually the actual recorded prevalence of some long-term conditions, you know better than I that because of an ageing population, the demands being placed on your time are even more significant. And that's why I think, irrespective of what happens politically, primary care will need to adapt and adopt and change. Now, we also know that 53% now of the population have some long-term condition. So what used to be seen as a spectator sport is now mainstream care. And this, for me, is the most fundamental challenge that primary care has to respond to. By the way, I don't believe there is any better people in the NHS in terms of your position to respond to the long-term condition challenge. Now, we also know, don't we, these are slides from NHS England and its recent consultation, a call to action. If you've not seen them before, just to let you know that I think what's interesting, apart from the increase, which you'll know more about than I do, is that the driver is the significant increase in consultation rates amongst the elderly. Now, we do know, however, that 87% of people that still express a preference believe that their GP system is very good indeed. And I'm sure you've heard before which political party in whichever country you care to think of has satisfaction ratings such as this. Just perhaps a word to the government as it's starting to think about renegotiating the GP contract. But it's not all plain sailing. As Saltman said here, the paradox of primary care is the tension between the relative weakness and unattractiveness of this level of care versus the intention to assign critical strategic functions to it, the squeeze. Now, this work by John Oldman, many of you will know John Oldman, presents 7 global challenges for primary care. I'm not saying all of these 7 apply equally and directly to the English NHS, but I reckon 5 or 6 of them certainly do. So in terms of adapting for the future, I would suggest that these 6 or 7 areas are the areas that we need to concentrate on. Speaking to Mark as I arrived today from Liverpool into Birmingham, clearly you know better than I how much pressure you're in just dealing with the day job. Now, I know that relative to other European countries, we have a better average, a blend between GPs and specialists, but in absolute terms, according to the Royal College of General Practitioners or Practice, perhaps 10,000 short over the next period of time. Now, we know that secondary care expenditure has been rising much more quickly than primary care expenditure over the last 10 years. I think it's a problem, but we do know that we are producing, in total quantum, enough doctors to meet the challenges for the next 7 years. The real issue is whether we can start retraining these people in flight. And this, I think, is one of the central questions for the NHS in the next 5 years. In the same way that some of us had a hand in writing the NHS plan in 2000, I think whoever wins the next election, there'll need to be another 5 or 10-year plan that makes sure they deal with this issue for general practice. If general practice wobbles, the whole system becomes less sustainable. However, I think you are better placed than any other party to capture the value chain. It's a horrible piece of management jargon, but in any country that I go to, it is almost developed country that I go to. It is almost a global truism that 1% of the population drive 30% of the costs, 3% of the population drive 50% of the costs, and 5% of the population drive 60% of the costs. I can't think of another industry on the planet that wouldn't actually really think very seriously about these people and the wider determinants of population health. Now, this slide here underneath is a slide from Kaiser Permanente. Often talked about, only 9 million insured members in the United States. We have all the foundations in our English NHS to be better than this. And if you look at this slide here, you can see getting to the top of the slide is the good old-fashioned tertiary teaching hospital. But anything up to then, I believe primary care has a stake in, or indeed can claim a stake in terms of managing the future. And the simple trick, says he smiling of course, in the next 5 to 7 years is to make sure that those patients have better personalised care, it's more proactive than reactive, it's planned and integrated and coordinated, and then patients are basically, their care is wrapped around that value chain. That is the mission that we face in the English NHS. And the best people to do it are the people sitting in this room. I'm not going to show you these 6 or 7 examples just to make you feel that you should be doing better, although I think they're quite innovative. The point of showing you these 6 or 7 examples is that you can see quite quickly that there are parts of the English NHS and primary care that are doing some of this already. The real trick is to do a lot of it simultaneously across the country. So just starting with the family health program in Brazil, I'm not suggesting England should be like Brazil, but their community teams that have reached into, that are controlled by GPs, a highly leveraged model of GPs, nurses, community care workers and assistants, working in communities much more proactively, looking at disease and sorting out disease. Couldn't we do that if we started to think about the future role of community hospitals and district nurses and, dare I say it, social workers as well in the future, all being led and managed and directed by primary care, point 1. In Valencia in Spain, their integrated model of primary care physicians and secondary care doctors, and in some cases tertiary care doctors, they've integrated their care pathways, their doctors are managed to the same objectives, they have an IT system that works and didn't cost the world, and you can see that their costs have been reduced by 12%. They also, of course, make sure they have a hospital specialist residing in primary care. In every one of their community clinics in Valencia, they have a specialist that's working in the right place, which is in the community in primary care surgeries. Now, I don't want to mention 111, but I do want to mention medical. I'm not suggesting that we have complete triage, but I was told only last night, ironically at the Foundation Trust Network conference, that the Hurley group are now doing a lot of online consultations, 60 or 70%. I don't know whether that's an apocryphal story or not. Here in Mexico, you can see that the default is to a telephone call or an email interaction before a face-to-face consultation. And look at the results, 62%. Now, if it's true the Hurley group are doing better than that, perhaps they're in the audience, that's amazing. Geisinger in the United States, just to give you an alternative model, is started as a hospital-centric organisation and then basically encouraged GPs to join the hospital group. I'm agnostic at the moment about which way it works, but you can see here, same patterns, common objectives, doctors working together, shared protocols, smart IT, reflective practice, proactive case management, and you can see here that the hospitalisation rate is reduced by 20%. The Blues in the United States. The reason why I wanted to mention this slide is that yesterday when I was talking to the foundation hospitals, and I hope that you feel the same, is that as I go around the country, I genuinely don't believe that people think having annual contracts, be they QOF payments or annual contracts between CCGs and hospitals, is going to do anything for the health of the population and the challenges that the NHS faces. Now, given that we've been told broadly that we have flat cash until 2020, then we have to start moving to longer-term value-based contracts which stop all this displacement activity of people trying to move financial bubbles from one place to the other. And you can see here, in terms of the work that the Blues did in the United States, you have a much better opportunity to pursue value. And I want to say a little bit more about the pursuit of value in a second, because one of our clients in the Netherlands, and the characteristics are not dissimilar to practices you will see, or CCG groups you will see around England. You can see here that what they're starting to do is move away from episodic payment either through the QOF or a consultation in a hospital, and they're looking at the 5 or 6 long-term conditions that consume the 30, the 50, the 60% of cost, and they're starting to contract for a year of care. Now, this is a Dutch system, which, let me tell you, is even more fragmented than ours, arguably. So my question to you is, why can't we do this tomorrow or the day after in the English NHS? Longer-term contracts, contracts focused on value. And the only plug I'll give you today, or perhaps I've got 2 plugs coming for KPMG. We've recently did a global piece of work on contracting for value. Most of it's pretty dull and turgid, but basically it says that actually the real quest in the next 10 years for most developed health systems is the pursuit of value, which crudely put is the outcomes of clinical quality divided by the costs of securing those outcomes. Now, the real shift in mindset is to move from volume-based payments to value-based payments. Now, I don't know what's going to happen to the QOF negotiations or the GP contract negotiations, but I think the real trick for the English NHS is to make sure we pursue value, not volume, and to better integrate the incentives between general practice and hospitals. Earlier this year, we brought together 20 different countries from around Europe, and Charles Alessi, who I know is in the audience, kindly came along as well. And we had a big conference of working general practitioners that were partners or owners in their own practices. And we basically tried to look at the 4 or 5 key trends for the future of primary care. Now, I'm not going to go through each one of these in detail. The 4 themes are here in front of you. I just want to touch on some of the key themes and hope that they resonate with you. So, early access to a senior clinician making decisions as early as possible, underpinned by communications technology. I'm not talking about connecting for health. You know as well as I do, last week I was speaking to a group of practice managers in Lincolnshire, that there are already technology solutions which are cheap and cheerful, that if managed properly and directed can do the trick. Also, this issue about continuity and coordination. With the political debate about the further integration potentially of health and social care, I honestly believe, as I've said before, the people that are best placed to manage population health are general practice working in primary care. And this issue about continuity and coordination, no other group can do what you do. No other group has the power to leverage care pathways in the way that you do. Now, I know that you're working very hard on the day job, treating patients, but I think these 2 things, on this particular theme in particular, single you out for having a very important role for the future sustainability of the NHS. Secondly, patients and populations, the blend of generalism and specialism, and also this issue about anticipatory care and population health. I think I've made the point on that, but some of the better practices that we saw actually in some of the Nordic countries were doing some of this very well. And what they were also doing, which once again I think you're largely uniquely placed to do, is leveraging community resources and assets. voluntary groups and facilities owned or perhaps directed or commissioned by the local authority. And this agenda of wellness and population health with stratification and segmentation of populations, the 1, the 3, the 5% of patients, I genuinely believe that's the absolute sweet spot of English primary care. The third area on information and outcomes, I think I've talked about community assets, but also would like to talk about the electronic record. There are now, as you know, practices in the UK that are developing electronic records that talk to each other and indeed to patients as well. I don't think we need to worry too much about connecting for health. Some of the systems that I've seen up and down the country are certainly fit for future purpose. And then coming towards the end of this part of the presentation, one of the things I was asked to address is, well, if primary care needs to adapt, what does it need to adapt to? And clearly, you know better than I, that the debate about federations or integrated structures in primary care probably won't go away. And clearly, I hope you see from what I'm talking about in terms of the test for primary care, I'm suggesting that we do need to bulk up. Primary care does indeed need to bulk up. And my 5 tests for primary care over the next decade are these 5. Number 1, can you manage more effectively and efficiently long-term conditions? I think the most important thing. Number 2, can you manage episodic incidents of illness better? Number 3, can you coordinate with health and social care better? Number 4, can you improve population health, particularly for those members of the population that are at risk or harm? And number 5, can you help deliver more care in the home? Now, if the answer to all those questions now is yes, then we're fine. If the answer to those questions is perhaps maybe, then I don't think we need a revolution in primary care. I don't think we need to beat up primary care. I certainly think we need more general practitioners in primary care. But I simply think that going back to the cat analogy, the model of small, isolated, independent or semi-independent practitioners is simply not capable of withstanding these tectonic changes in our society and the population that you care for. And therefore, in one sense, I think the debate about federation, and I think we might have some time for questions and answers for me, is how do you federate where there is no consensus among consenting adults? So do we need a harder edge to that discussion, or do we just simply need more experimentation up and down the NHS? In summary, most countries in the world would cry out for our primary care system. We should treasure it as a national asset. We should recognise that it's served the country very well to date. We should understand that the changes in our population mean that we all have to change, and it's an adoption, an evolution, and adaptation rather than a revolution. So that's all I'd like to say. I'm happy to take some questions, Mark, and thank you very much indeed for listening to me.